I'm Dr. Craig Joseph.
And I'm Dr. Jerome Pagani. And this is DocTalk.
With the introduction of a novel coronavirus in late 2019, the world has been enveloped in the worst pandemic in a century. It is estimated that globally some 6.5 million people have died as a direct result of the SARS-CoV-2 virus. Beyond that horrible statistic lies the unknown future morbidity and mortality of long COVID. This phenomenon affects a significant percentage of those infected with symptoms that range from brain fog to heart palpitations to shortness of breath.
The economic burden of long COVID is difficult to estimate. U.S. Census Bureau Household Pulse Survey recently found that around 16.3 million working-age Americans have long COVID. The Brookings Institute conservatively estimated that 1.6 million FTE U.S. workers could be out of work due to the lasting effects of the virus, and other estimates put that number as high as 2 to 4 million. The annual cost of those lost wages is around $170 billion, nearly 1% of the U.S. GDP, with the potential to be as high as $230 billion.
While the international medical community is working on standard ways to identify and label patients with long COVID, we have some way to go before we can agree on what constitutes the phenomenon. We're even further away from offering specific therapy. Currently, we are treating the symptoms of long COVID because we really don't understand the causes. Beyond the new onset of cardiac, neurological, and other symptoms, the CDC reports that some people, especially those with severe COVID-19 disease, experience new onset autoimmune conditions such as diabetes mellitus or hypertension.
The burden of long COVID doesn't just fall on the patient. The U.S. medical community has been overwhelmed since before the onset of the pandemic. We are already facing a clinical tsunami, increased costs, labor shortages, and high utilization of services, what we at Nordic call the big squeeze. Long COVID will add millions of additional patients to the mix, and these folks will likely consume significant resources. A preliminary study released this year found that patients with long COVID have a healthcare utilization rate 11% higher than average. Now is the time for health systems to prepare for these patients.
Even if the predictions for the number of long COVID patients and the severity of their symptoms is only half as great as projected, physicians and healthcare executives are at risk of being overwhelmed. We must leverage all the tools we have to anticipate the realistic needs and build the necessary resiliency and operational resources into our systems. Technology will be essential, but a complete solution for healthcare delivery will necessitate a click-and-mortar approach. The right combination of people, technology, and physical facilities that works for those receiving and delivering care. So this research involves us asking you questions, and when you get them wrong, we shock you.
Do you have human subjects approval for this?
Hello!